Good morning, ladies and gentlemen. It's a very heartening thing for me to have come. This is my third time in Bangladesh now. Very grateful to the entire chairmanship of BABIP. Are you able to hear? Yeah. So very grateful to the entire chairmanship of BABIP, especially my great thanks to the professors Mirza Hiran, Bishwas Hussain and Saidul Islam, and of course my thanks also goes to Abdul Razak sir, Khairul Anam sir, Nihar Ranjan Saha and Bipul Biswas, and my good friend Nirmal Kranti Sarkar, who's going to be the next speaker. The task today at hand for me is to speak on argon plasma coagulation, and we call it the wings of fire. And why I call it the wings of fire, I'll tell you through my talk at a later point in time. This is the hospital from where I come. This is called the Narayana Health. On the left of your screen is the cardiac hospital, and on the right is the hospital in which where I work on the first floor, and that's the Mazumdar Shaw Medical Center. So I bring greetings to you, ladies and gentlemen, from there. So this is a common problem that we continue to see. Either it's benign or malignant disease, which can obstruct the airways. This is a basic common interventional problem, and patients usually present either with dyspnea, cough, pneumonia, or with blood in the sputum, which is hemoptysis. And there are multiple endobronchial modalities which are there to treat these disorders using either rigid, which is the standard of care in interventional pulmonology now, or you can even use your flexible bronchoscopy, which is more widely available. Now, before I go into the matter per se, this is the overview of how the hot and cold therapies look. So today's entire conference, which is on fire and ice, basically will tell you that either there are hot modalities or cold modalities. By the way, for those people who are taking pictures, do not hesitate. This is my email ID, kedarhibari@gmail.com. You can just write a mail to me. I'm happy to share this entire presentation. This is a teaching slide set, so you can take a photograph of this, kedarhibari@gmail.com. So I'm happy to send you my presentation. Okay, so the hot and cold modalities. So either your modality is hot, either it is cold, or it is neither. And if it is a hot modality, then we use contact or a non-contact method, and the contact methods are electrocautery, which Nirmal Da is going to be talking about later. The non-contact methods are basically the APC, laser, and for laser in pulmonology, we usually use the Nediag laser. If you talk about cold modalities, Professor Syedul has already detailed to you the cryotherapy, and we have 1.9 and 2.4 mm reprocessable probes, while the 1.1 and the 1.7 are the disposable probes. And when you neither use hot nor cold for debulking, there's another modality which is neither hot nor cold, and that's called as a micro debrider. It was very popular at one point in time, went into disuse, but is getting again back into focus right now. The modalities can also be classified as rapid or slow. And when we're talking about rapid modalities, of course, electrocautery, APC, and laser. Of course, mechanical coring, which you can do with your rigid bronchoscope. The slow modalities would include cryotherapy, photodynamic therapy, and brachytherapy. There are a lot of confusing terms, and one of the terms when we are talking about hot therapy is electrosurgery. And one of the things that we need to understand is how is electrosurgery different from all of these. So it's nothing but electrosurgery refers to the thermal property of electric current, and it is used to destroy tissue or coagulate bleeding sites. And the synonyms that are used in literature are electrosurgery, electrotherapy, surgical diathermy, and basically meaning the same thing. It's nothing but the use of heat for tissue destruction. And when we want to use either the hot or the cold therapies, one of the prerequisites is the fact that the lesions should be short, and they should either be in the trachea or in the main stem bronchi. Usually the lung which is distal to these lesions in the airways should basically be visible, patent, and functioning. So if you have a non-patent airway, please ensure that on the CT scan you look for viability. And of course, if it's an acute history, young patient, then it actually helps you because that is when the airway is likely to open up. Okay, so the outcomes basically improve with case selection and the choice that you want to use. So what are the indications? And indications for electrocautery and APC are more or less the same. So what we use hot therapies for is to recanalize malignant airway stenosis. Bleeding is one of the most important things that happens with argon plasma coagulation, and that's really why it's so important. We can even recanalize occluded stents, and probably Abhishek Bali, my colleague who's come from India, will probably take you through a couple of videos later in the day. And there are, of course, other indications like benign endobronchial tumors, fistulas, which can be conditioned before you actually decide to put glue, or you can even treat scar tissue by using these things. So how does the choice depend? So which one to choose? I get often asked, do you want to use APC? Do you want to use electrocautery or laser? How do we decide? And I hope to shed light through my talk over that. So one is, look at the clinical presentation. What is the acuity of the presentation? In the sense that, is it a hyperacute kind of a setting in which you have ended up with the patient, or the patient is gradually developing dyspnea and hemoptysis over a period of time? Decide on what modalities that you are going to use in such a setting, whether it's rigid or whether it is flexible, or you want to use one through the other as a conduit. The other thing is, of course, your own training. If you have more training in rigid bronchoscopy, it's much more easier to use. But again, rigid bronchoscopy also means you need an OT setting and you need an anesthetist with you. The availability of equipment plays a major role. Risks and benefits with the kind of instrument that you want to use plays a role. And of course, all of this has cost implications, especially in Southeast Asian countries like ours. Before we go to the topic per se, we need to understand how and what temperature and how does the tissue react. So as your temperature basically increases, these are the effects. So at about 40 degrees, you end up with a hyperthermia, which is what most of us in the Southeast countries experience. But as the temperature starts going up to 60, the tissues will start to devitalize. You move up a little more to 100, there is desiccation. You move to 150, there is carbonization. And if you go even up, which is about 300 degrees, that's when vaporization happens. So what is important to understand is the first three effects are the ones which we are aiming for with the use of electrocautery and APC. But as you move up the ladder, or you start using something like a Nidiag laser, you can even cause vaporization. Okay? So when you absolutely have an airway situation which is completely blocked, a near total block, laser can come in very handy, because there you don't have to debulk. The entire tissue will get vaporized. So you don't even have to take out the black scarry tissue that is left after your burning. And what is the depth that you achieve? So with APC and electrocautery, it's usually the mucosa and just hits the submucosal level. So it's about 5 millimeters at most. Beyond 5 millimeters, electrocautery and APC really don't do anything. So let me introduce argon plasma coagulation, which is actually what I am concentrating on, and I told you Nirmal is going to talk about electrocautery. So what is basically APC? It's a new electrosurgical method, and the bleeding is the one which actually got the gastroenterology and the surgical community to come together to decide and discover this modality, and that's how the development of APC came along. So it's bleeding that is the central focus of argon plasma coagulation. And basically what happens in this is argon gas is ionized by an electric current to create a non-contact homogeneous bridge. And that's basically the bridge that with the transfer of heat causes coagulation and ablation. The first such papers started coming out way back in 1994. This is the first paper on argon plasma coagulation in endoscopy. There was use of APC in surgery and in gastroendoscopy before, but the first paper in bronchology came in 1994. This was a paper by Stork and Farren. Excuse me. So what actually is argon and why is this important? It's colorless, it's odorless and tasteless. We have argon in the atmosphere, and it's only 0.93% by volume. It's chemically inert, it's non-toxic, and the transfer, and for transfer of energy, you need to have a concentration of gas which is quite high at the tip of your probe. So this is what the probes look like and the construction looks like. It's actually a tungsten material. Non-contact form of electrosurgery uses ionized argon. The presence of high voltage electric field is ionized, and it basically creates a monopolar current which creates this particular transfer, and heat energy is produced causing coagulation and hemostasis. The principle is nothing. What actually happens is extracellular water gets evaporated and it denatures the protein in our tissues, and that basically leads to the destructive effects that APC basically produces. And the current seeks to conduct to any surface, and the circuit is basically caused by the 1 centimeter gap that is basically required. So you move more than 10 millimeter, the circuit is not complete, and therefore the transfer of energy does not occur, and it occurs only when the gap is about 10 millimeters. So this is basically what I was talking about. The current requires a closed circuit to propagate. Without this circuit, there is a problem. If you move too close, it just becomes like an electrocautery and the transfer of energy does not occur. So that is a suboptimal, technique. So what you need to do is always have a distance of about 10 millimeters, which is about 1 centimeter between your probe and the tissue. And that's why we call APC the non-contact method of energy transfer. Of course, you require settings of 40 to 80 watts. So just remember that we are not using too high a temperature. The pulses are only for 2 to 3 seconds and the depth never goes beyond 5 millimeters. So you can't inadvertently cause a deep burn in such situations. It's usually only the superficial burns, and this over a period of time sloughs off, and therefore the tissue becomes better with time. Sorry. So this is a very interesting graph, and I'm going to spend a little bit of time. On the x-axis is the application time, and you can see that application time of 10 seconds is what we are looking for. And on the y-axis, we are basically looking at the depth of coagulation. So see that even if you keep an application time of 10 seconds on APC, you are never exceeding the depth of about 4 millimeters. So it's always superficial burns, and this superficial burns is the cause why APC is the best modality for hemostasis. So this is basically the equipment. What you see on your left is the older APC and electrocautery machines by Urbe, and now it's much more sleeker, more standard, more software, and more better hardware than before, and that is the YO3 machine with the APC3 argon unit. And again, like I was telling in a couple of slides before, this is a non-contact method. So see the picture on the left. You require to have that gap for the transfer of energy. So if you don't give that gap, that energy transfer does not happen, and therefore you will not be able to get adequate hemostasis. So non-contact method, minimum distance 10 millimeters. So what is the technique? So basically you have a grounding pad because you want to create a circuit. The patient has a pad on his body. You can put it closest to the surface where you're doing it. The power settings are between 30 to 120 watts, but usually 50 is more or less sufficient. That is the setting that's on my APC machine. The application time, depending upon the mode, is about 2 to 3 seconds. The argon flow rate, which is automatically adjusted when you attach the cylinder, is between 0.3 to 2 liters. And 10 millimeter, like I've stressed multiple times, should be the distance to the target tissue. Okay? Of course, there are 3 different modes. You have a pulsed effect mode 1, APC pulsed effect 2, and APC forced mode. So these are the 3 modes. If you look at the entire table, you will see that almost everything is same except these aspects where the effects will either cause a deeper coagulation, a superficial coagulation, or a superficial to deep thermal insult. So what these modes differ is in only the kind of after effect that it will show up after doing the procedure. So that's basically what the modes will do. Otherwise, the argon plasma, the wattage, the hemostasis, everything almost is the same. So what is a forced mode? So like I said, there are 3 modes: a forced mode, a pulsed mode, and a precise mode. So let's go to the forced mode first. So what happens in a forced mode? There's consistent firing at 30 watts or above with an application distance of 5 millimeter. So that's basically the forced mode for you. In pulsed mode, as you can see in the graph, there are multiple pulses of electrical activity that the generator gives off, and that's basically what causes the kind of effect, and therefore it's not a sustained kind of a response that you're giving for the electrical current. And for the precise mode, what happens is the intensity of the ionized plasma increases with the effect setting is increased. So that's basically what the precise mode is all about. Interestingly, Urbe has 3 different tips. One is an axial one, a side fire one, and circumferential. The circumferential probe gives out a circular kind of a burn effect. The side fire is the one which is my own personal favorite, and it gives you only burning in the area in which you actually want to target. While the axial also does a good job, but sometimes twisting and turning your bronchoscope can become a problem in difficult areas. But again, like I said, APC has this particular property that it can bend at the surfaces, and therefore it doesn't become a big problem if you have an axial probe as well. So axial and side fire are probably the most commonly used ones during bronchology treatments. So what does your factors, what are the factors that affect tissues? One is the duration of activity. The second one is the power setting on your machine, and the third one is the probe distance. So these are the 3 factors that affect APC use. And one of the other things that, like I said, I get asked is, how does how does APC fare when compared to electrocautery or with laser. Now let's compare APC with electrocautery. So what happens in electrocautery is the current penetrates tissue in a much lesser predictable fashion when compared to APC. So therefore it is quite erratic, therefore APC scores over electrocautery. The depth can exceed a few millimeters in relatively a short period of time, and spray coagulation is possible. Tissue effects though are same. When it comes to lasers are extremely costly. The machine and the equipment is huge. It occupies a lot of space in your bronchology unit. It has more penetration and therefore a larger burn effect. It causes less hemostasis when compared to APC. There is a site dependency when it comes to laser, and of course there are extended safety precautions when you want to use laser, because you have to use goggles and therefore your vision impairment will be there. And it can cause problem with stent. So if you have a stent and you use a laser, you can burn that particular stent as well. But when you're doing it with APC, it's economical, lesser penetration, amazing for hemostasis. The depth and the effect is much controllable with the power settings. The machine is much more smaller and sleeker. There is no need for you to use extended safety precautions, except the fact that your FiO2 should be less than 0.4. So that's the reason why, again, APC scores over laser as well. These are various studies. I'm not going to go into it, but I think what I will focus on is these 3 studies. This is the electrocautery and bleeding in endobronchial lesions, and actually there are 3 papers. The largest one is by Risch, and here they had 115 patients where APC was used. This is probably the largest study on APC, and what happens here is the fact that they've shown that APC is probably the best modality when it comes to achieving hemostasis in endobronchial bleeds. Now, I was always talking about why my topic is called the wings of fire, and the reason I call it the wings of fire is because APC's burning ability can even bend when you have airways where you want to, in the branching points. And that's why, you know, since it flies, the fire flies, therefore I call it the wings of fire. So before I end my talk, in the morning somebody actually spoke about Robert Frost, and this is my favorite poem on fire. So this is very interesting, and I'm going to read it out to you guys. Fire burns red and hot, inside and out. Some ignore it while others shout. It can be used for good or ill, used to save or used to kill. Fire burns passionate and deep. They give us strength when we wish to weep, or they burn us, make us a rash. Their only goal is to see us crash. Fire burns fierce and strong. They care for not what is right or wrong. Put them out or watch them burn. Let them go and watch and learn. Last but not the least, fire burns without control or thought. It runs its course and it can't be caught. Whether for good or for bad, we'll always have fire, and we should always have it. Thank you, ladies and gentlemen, for a patient hearing.